Hi, everyone. Thanks for joining us today. We'll give people about one more minute. It looks like a bunch of people are signing on. We'll give people one more minute and then we'll go ahead and get started. Okay, hello everyone. Let's go ahead and get started. Thank you so much for joining us for our latest academic series. It's my pleasure to introduce Dr. Harfouche, who is going to be our speaker today. Dr. Harfouche initially started her training, her medical school at Mount Sinai. Following that, she went to residency at Temple, and after that, she did her fellowship at the R. Adams Cowley Shock Trauma Center. She liked it so much, she decided to stay, and so she is now an assistant professor of surgery there. She has done extensive research and has won many awards both through AAST and through AAST. She was the Templeton Scholar for her work on violence prevention research, and she has also been a AAST Scholarship Award recipient. She conducts research in three main domains: violence prevention, hemorrhage control, particularly talking about ROBOA, which she won't be talking about today, and severe acute pancreatitis. I think that personally, this is something that I find very, very challenging to treat. And so I'm very excited to hear your insights and to learn from your talk. So thank you so much for joining us today, and I can't wait to hear your talk.
Thank you so much, Dr. Golestani, and thank you to the associate membership leadership for this opportunity. I am very proud to be an associate member, and I'm so impressed with everything that the group has accomplished. I'm really looking forward to seeing what's next. So let's get started. My talk is titled Acute Infected Necrotizing Pancreatitis, the Not So Good, the Bad, and the Ugly. I have no disclosures. So let's start off with the tale of JL. JL is a 30-year-old woman who came to an outside hospital with alcohol-induced acute pancreatitis. She was treated with the usual acute fluid resuscitation, but unfortunately developed abdominal compartment syndrome and underwent a decompressive laparotomy at that outside hospital. At that point, the resources of that hospital had been depleted, so they gave us a call to transfer the patient to the University of Maryland for further care, and she was transferred here. When she arrived, this is what her abdomen looked like. Obviously, very edematous, very much loss of domain. She was treated with several abdominal washouts and ultimately got a vicral mesh. I want to point your attention to this area of necrosis here, and eventually that developed into more of a hematoma appearance, and then ultimately area of necrosis. And as you can see here, full atmospheric fistula. Now, this is just one of the many things that can happen to people with an infected necrotizing pancreatitis. It's not a disease that follows an expected course. It can come on rapidly and cause the failure of several organs, leading to acute renal failure, respiratory failure, florid sepsis, and the devastating complication of abdominal compartment syndrome. Or it could fester and grow slowly, wreaking havoc on the surrounding tissues, causing GI bleeding from erosion into the stomach or the duodenum, enteric perforations and fistulas to the colon and small intestine, bowel obstruction from the extensive inflammatory reaction it causes, or a disconnected pancreatic duct from chewing into the main pancreatic duct. It can cause thrombosis of splenic veins. The portal, splenic, and SMV are the most common. This can lead to ascites, liver failure, or the inflammation can erode into the splenic artery or branches of the gastroduodenal artery, causing massive retroperitoneal hemorrhage. Infected neck panc is a shapeshifter, a chameleon of sorts, as I like to think of it, and the morbidity and mortality it causes in our society. is very significant. But before we dive into that topic, let's go through our outline. We're going to start off with the epidemiology of acute pancreatitis. We'll go through the main classification system as we have it today, management approaches, some controversies as it pertains to these approaches. I'll finish up by talking about JL and what happened to her, and then hopefully there'll be some time at the end for some questions. By the end of this talk, I would like you to be able to describe and classify fluid collections in acute pancreatitis, understand the different management modalities specifically pertaining to infected neck panc, and last but not least, appreciate some treatment nuances and considerations. So, what is the epidemiology of acute pancreatitis? Out of 10,000 individuals in the US population, 40 of them will present to the emergency department in the United States with acute pancreatitis each year. You can see those 40 individuals represented here. From that group of 40, approximately 20%, so 10 out of that 40, will have a severe form of that disease. From the group of 10 individuals with that severe disease, 2 or 20% will go on to die. The remainder will suffer significant morbidity, including prolonged hospitalization, ventilator dependence, and additional complications like I mentioned previously. So although acute pancreatitis may have a low overall incidence, it has a very high hospitalization cost of about $2.6 billion per year in the United States. The etiology of acute pancreatitis is attributable to two main disease processes. The most common is gallstone related, which accounts for 60% of cases. And the next most common cause is alcohol-induced, which accounts for 30%. The remaining 10% of causes are due to hypertriglyceridemia, which is 5%, as noted here. And the remaining 5% is due to a combination of diseases, such as post-ERCP, medication-induced hereditary pancreatitis, and injury-related, which includes both traumatic injury and iatrogenic causes. Now, before the development of the Atlantic classification system in 1992, there were several other classification systems, and I won't bore you by going into those details. But because CT imaging was not widely available when those classification systems were developed, they were based very heavily on pathologic findings at the time of autopsy or surgical intervention, which honestly isn't that helpful for practicing clinicians who needed to know how to manage the patient in front of them. But the advent of CT changed everything. And that is what led to the development of the Atlantic classification in Atlanta, Georgia in 1992. 40 experts from around the world convened over 3 days to come up with a better classification system for acute pancreatitis. The meeting was aimed at predominantly helping clinicians appropriately characterize patients for the purpose of clinical management, and also to build international consensus so that these findings could be shared across research communities. And they really focused in on severe acute pancreatitis. And one of the most important things that the classification did is describe the radiographic appearance in SAP. They divided the disease into two main forms. The more severe form associated with greater morbidity was necrotizing pancreatitis. And the more common and less severe form was described as interstitial edematous pancreatitis. They also emphasized that organ failure or local complications could be a part of severe acute pancreatitis, that they did not have to occur together. And within the local pancreatitis complications that could be seen, they described 3 unique presentations, one being abscess formation, which they defined as a distinct and much less nefarious form than the other local complication, which is necrosis. They described abscess as a collection of pus in close proximity to the pancreas without any coexistent necrosis. Now, necrosis itself was defined as 30% or more of the pancreas appearing necrosed on CT imaging. And last but not least, they described a pseudocyst, which was a collection of pancreatic juice with a distinct fibrous wall that usually occurred about 4 weeks after the onset of acute pancreatitis. Within this classification, they also introduced a more nebulous concept, which was the acute fluid collection, giving it a description that was more specific than had been found in previous classifications. And it was known at the time that about 30 to 50% of severe pancreatic cases had fluid collections in the early phase before 4 weeks of disease occurrence, and the majority of them regressed. So this really started to form the building blocks of the classification system that we find today, which is the Atlanta Classification System of 2012. Between 1992 and 2012, a lot happened. New words started emerging in the literature, such as infected pseudocyst, necroma, and although they had really tried to get rid of the word phlegmon, it kept coming up more and more in the literature. So what was increasingly realized was that there was more of a nuance to this disease process than the 1992 classification really encompassed. And they realized it was a little too crude to really capture the extent of what was going on with these patients. So in 2012, an international working group met again. This time they used a web-based form to get responses from several national and international pancreatic societies to create the consensus document we find today, which is the 2012 Atlanta classification. One of the main things they did was make the process of diagnosis much clearer, which is the diagnosis process that we use today. And that is, you have to have 2 or more of the following findings. 1, classic epigastric abdominal pain that is persistent and radiates to the back. 3 times elevation of serum lipase or amylase. And the last criteria, which is optional, and that is CT findings consistent with inflammation of the pancreas. And I put here, it's really important to think before you CT, especially when the ED calls you with a consult for acute pancreatitis. Don't just reflexively say, we'll get a CAT scan, because you only need 2 out of 3 of these diagnostic criteria to make the diagnosis. And if you image these patients really early on in their disease process, you may not appropriately classify them and categorize them into the appropriate morbidity and mortality prediction with their disease process. So that things evolve over time, and it's much better to get your CT imaging at least 3 to a week into someone's disease process than early on in their admission. So now I want to go through how the Atlanta classification classifies pancreatitis based on its radiographic appearance. And the first branch point is how the pancreas itself appears. The most common presentation is interstitial edematous pancreatitis. And here you can see the classic appearance of interstitial edematous pancreatitis, where you have a diffuse edematous pancreas that is fully enhancing. The arrows are pointing to the peripancreatic fat stranding, but what you really see is this enlarged pancreas. The other form of acute pancreatitis is the necrotizing form. And what's specific about this is that you have a non-enhancing pancreas. And it goes without saying that it's really important to image these patients with IV contrast so you can make these distinctions. And if you image them really early, you may not see the necrosis developing. Here you can see total necrosis of the pancreas. None of it is enhancing. And another subset of necrotizing pancreatitis is where the necrosis is limited to the peripancreatic tissue, and the pancreas itself is actually fully enhancing. So you can see the stars are on a fully enhancing pancreas, so that's perfused, not necrotic, but the arrows are pointing to the peripancreatic tissue that is necrosed. Interestingly, a study done out of the Mayo Clinic in 1999 compared mortality in patients who had this subtype of necrotizing pancreatitis to the form that had the necrotic parenchyma itself, and they found a much higher mortality in the necrotic parenchyma group. So the peripancreatic necrosis group did about a third lower mortality than the group that had the necrotic pancreas. All right, so moving on, if fluid collections develop in the course of acute pancreatitis, they're categorized specifically based on whether this is an interstitial edematous pancreas or a necrotizing pancreas. So going down the interstitial edematous pathway, if you develop a fluid collection early in the phase of acute pancreatitis, within 4 weeks from symptom onset, this is known as an acute peripancreatic fluid collection. And you can see here, the cuts of the pancreas that you can see, it's fully enhancing, so edematous, and the arrows are pointing to this hazy, homogeneous fluid collection without a clear wall that is classic for an acute peripancreatic fluid collection, so an APFC. Like I said previously, most of these fluid collections will resolve and not cause any problems. After 4 weeks into the course of this disease, this acute peripancreatic fluid collection, if it does not regress, will form into a pseudocyst. And you can see here, this was one of our patients' case report that one of our nurse practitioners published, Janet Lee, in 2023. And obviously, this lady is pregnant, and the main diagnostic dilemma here was, well, how do we manage labor in the setting of this massive pseudocyst? She was also unable to eat at the time, so nutrition was a concern as well. But ultimately, what we decided to do was she underwent a C-section, and at the time of her C-section, she had endoscopic drainage of her pseudocyst. But the classic appearance of a pseudocyst is this homogeneous fluid collection with a rim-enhancing wall, which indicates that the cyst has matured. Now, moving to the other side, the necrotizing form of acute pancreatitis, if a fluid collection forms in this subset of pancreatitis, it is known in the early stage, less than 4 weeks from onset, as an acute necrotic collection. And this is really where the confusion begins in our radiology reports and how we talk about these patients, because you can see here how this fluid collection looks very similar to an APFC. But if you look a little bit closer, you can see kind of this area of central necrosis that indicates that this is a more heterogeneous fluid collection. But in situations where you're unsure what to call the fluid collection, just remember, if there is necrotizing pancreatitis and a fluid collection in the early phase, it is an acute necrotic collection. It is not an APFC. And this is important to know because there's a much higher morbidity and mortality associated with necrotizing pancreatitis. So if you misclassify these patients, you are erroneously placing them in a much lower risk category. Some people even recommend getting MRIs to better distinguish these collections, but we often don't do that. Aside from the heterogeneous appearance of this collection, you also notice that there's no wall to it, indicating that it's very much in its immature form. And moving on, after the 4-week period, these fluid collections, these acute necrotic collections, will become walled-off necrosis. And you can see here, these arrowheads are pointing to the heterogeneous aspect of this collection that contains both fluid and solid contents. And the arrows are pointing to the mature wall that is indicative of walled-off necrosis over an acute necrotic collection. Now, the other thing that the Atlantic classification did, besides helping us identify these fluid collections based on CT imaging, was it helped define the severity of disease. And you will see later how important this is to predicting a patient's course. And they divided the severity into 3 categories, the first being mild, the second being moderately severe, and the third being severe. The mild form of acute pancreatitis is defined by the lack of any organ failure, no local complications, meaning no fluid collections, no colonic necrosis, no gastric outlet dysfunction, no splanchnic thrombosis. and also no systemic complications. You may be wondering, well, what does that mean? What's a systemic complication? That is exacerbation of an underlying comorbid disease. So like COPD exacerbation, for example. Moderately severe disease is defined as the presence of transient organ failure. So this is organ failure that goes away within a 48-hour period. And you may or may not have local or systemic complications. And I want to emphasize here, the important point is the organ failure, because as we move on, you'll see how important organ failure is. The Marshall score is what the classification system used to define organ failure. And if you had a score greater than or equal to 2, you were defined as having it. And the systems that are included in the Marshall score are the respiratory, the renal, and cardiovascular systems. So for instance, if you have a P to F ratio that's less than 300, that gives you 2 points. A serum creatinine over 1.8 in a person with normal renal function is also 2 points, and a blood pressure less than 90 that's not fluid responsive is also 2 points, just as examples. So a pretty simple system for classifying organ failure. And last but not least, what gives you severe acute pancreatitis? And that is persistent organ failure. So organ failure that lasts over 48 hours with or without the presence of local or systemic complications. And you may ask, why does organ failure matter so much? Why this heavy emphasis on organ failure? Well, not surprisingly, it has a huge effect on mortality, much so than the presence or absence of fluid collections. So if you look at these 3 studies here that were published almost 2 decades ago, you'll see that the in-hospital mortality rates of a person with no organ failure is less than 5%. When you have transient organ failure, that mortality rate ranges anywhere from 0, according to the Buter study, to 18%. But if you have persistent organ failure, your mortality can be anywhere from 25 to 55%. So very important prognostic criterion. All right, now let's move on to the meat of this presentation and the topic that I find most interesting within acute pancreatitis, and that is infected neck panc. This is the clinician's worst fear, the enemy. Once it develops, there's concern for enormous morbidity and mortality. I also see this as, the holy grail of research. If we can figure out how to prevent this complication from developing, then we can save a patient's life and years of morbidity. So let's go back to the 40 patients that are coming to your ER every year with acute pancreatitis. Of those 40 patients, 10%, or about 4, will go on to develop necrotizing pancreatitis. From that group of 4 individuals, half will go on to develop infected necrotizing pancreatitis. First, I want to talk about how you diagnose this disease process. In the modern era, we diagnose infected necrotizing pancreatitis with CT imaging. In the event our CT imaging is not convincing for the presence of infected necrotizing pancreatitis, clinical suspicion is sufficient to make the diagnosis. So a patient with known necrotizing pancreatitis who is clinically deteriorating in the absence of confirming CT findings. And last but not least, FNA can also be used to make the diagnosis. This has really fallen out of favor. And the reason for that is because, one, there's a high false negative rate. So you may not properly treat a patient who needs to be treated for infected neck panc. 2, there may be some delays in getting an interventional radiologist to do this procedure for you. And last but not least, you may infect a fluid collection that's not infected. So it has been a very long time since I've seen us do an FNA for this diagnosis. Now, what does this look like? Going back to our classification system, you've got the patient with necrotizing pancreatitis who develops an acute necrotic collection, then they develop a walled-off necrosis, And then you start to see these gas pockets appearing. And this is shown by the arrowheads here. It's a bit hard to see if this fluid collection has a thick wall. Now, you can get infected necrotizing pancreatitis at the early stage too, at the acute necrotizing collection stage. But it's really defined by these gas bubbles in the fluid. Now, what happens if you get both? And this is a quite common presentation of organ failure with infected necrotizing pancreatitis. If you look at the study by Petrov published in 2010, in the absence of organ failure and in the absence of infected necrotizing pancreatitis, your mortality in the setting of acute pancreatitis is less than 1%. If we shift up to just infected neck panc alone, the mortality with no organ failure, that mortality is 11%. If you've got just organ failure alone with no infected neck panc, it's 22%. But the two in combination severely increase your mortality to 43%. So then the question then arises, how do we reduce mortality in patients with infected necrotizing pancreatitis after it's developed? This is a direct quote from the 1992 Atlantic classification publication that said, while selected patients with documented sterile pancreatic necrosis can be treated without surgical intervention, infected necrosis is fatal without surgical drainage. So to underscore, it was believed at the time that once infected necrosis was diagnosed, surgical drainage was absolutely necessary to survival. So up until the early 2000s, this was the predominant approach to treating infected neck panc. Once a patient was suspected to have acute pancreatitis, they were admitted, they're observed, and if they had signs of clinical deterioration, an FNA was performed. A bacterial culture was sent, and if it was positive, the patient was taken for an open necrosectomy. This was performed with a bilateral subcostal incision. Adhesions were lysed. The gastrocolic ligament was opened. The lesser sac was entered. And whatever could be debrided at the time was debrided. And the patient was taken back every 2 days for further debridement until ultimately 2 large drains were placed and the abdomen was attempted to be closed. Not surprisingly, at the time, this was associated with very high morbidity and mortality rates, with morbidity nearing 90%. And what remained really unclear at the time was if this was even necessary. If you remember that quote from the Atlantic classification of 1992, they emphasized that surgical intervention is paramount to survival. But with such high morbidity rates, people started questioning if this was really necessary. And it was a landmark study done several years later that really transformed how people thought about the disease process at the time. So it was known in the 90s that acute pancreatitis mortality had 2 main peaks. One was in the early stage, which occurred within 14 days and was due to a dysregulated inflammatory immune response that really overwhelmed the body's organs and led to multi-system organ failure, ARDS, and death. And then the second stage, which occurred after 14 days, where deaths were defined by sepsis due to infections and sepsis-induced organ failure. And this debate was going on whether early surgical intervention reduced mortality and whether whether it should be delayed. And then Mir came along with his study in 1997, which was conducted in Mexico City. And it was one of the first randomized clinical trials to answer this exact question as to whether early or delayed open necrosectomy was preferred. So between 1990 and 1993, they took the sickest of the sick with acute neck panc, individuals who were clinically deteriorating, had multi-system organ failure, and they randomized them to early surgical debridement within 48 to 72 hours of diagnosis. and delayed debridement, which was after 12 days. 36 patients were randomized in the study, which was actually cut short because of the findings. And what they found was that mortality was almost 3 times higher in the early open necrosectomy group at 56% versus 27% in the delayed group. And in the group that had culture-proven infected neck panc, that difference was even greater, 73% in the early group, 29% in the delayed group. So this study really set the stage for the pendulum of how we manage infected necrotizing pancreatitis to swing away from early aggressive open necrosectomy to a much less invasive and a delayed approach. And what I'm going to talk to you about next are 3 trials that have really transformed how we care for these patients today. The first is the PANTER trial. All 3 of these trials were published by the Dutch Pancreatitis Study Group. This first trial wanted to compare whether a minimally invasive approach to infected neck panc had better outcomes than an open approach. So they conducted this at 19 different academic centers. Inclusion was limited to patients with CT-confirmed pancreatic necrosis. An expert panel was convened to determine whether or not a patient qualified for the study and an intervention was needed. When it was decided that they qualified, they aimed to postpone intervention to after 4 weeks of disease onset, like the previous study that I discussed. And the 2 groups that they were randomized to was the percutaneous step-up group, which predominantly included a retroperitoneal percutaneous drainage approach with a 12 French drain, followed by a second drain within 72 hours, and if no improvement, a video-assisted retroperitoneal debridement. I put an asterisk there because there were some patients who got endoscopic debridement in this study. The other group was the open group, where they got the standard bilateral subcostal incision, debridements with drains, with return to the operating room if needed, depending on surgeon preference. And the main outcome they looked at was a composite of major complications or death. And the findings, which many of you may know, were predominantly in favor of the step-up approach. The composite outcome of complications was much lower in the step-up approach at 40%. There was much lower onset of onset organ failure, obviously less incisional hernia, less use of pancreatic enzymes, and less new onset diabetes. So this really shifted practice patterns, not only to delayed intervention, but to a minimally invasive approach. I want to touch briefly on the VARD procedure, so video-assisted retroperitoneal debridement. It's really important when you are considering this treatment modality for a patient that the location of drain placement is paramount, and you should call your interventional radiologist and go through the scan with them and ask them specifically where you'd like them to place the drain. Preferably not between ribs, but you have to balance that with the distance of drain placement from the collection itself. What you don't want is a really long tract to the collection. So sometimes you may have to compromise the range of motion that comes with placing a drain between the rib spaces to having closer access to the collection. You cut down directly onto the drain. It's a pretty generous incision. Go through all the muscles, and then once you enter the infected pocket, if it's really right there, you can use a ring forceps and start debriding directly, being very gentle, not to pull too much. You can avulse a vessel, cause bleeding if you're too aggressive. If the collection is further away, what I will typically use is a nephroscope because it allows for continuous irrigation at the time, which improves your visibility, and you also have a secondary channel through this nephroscope where you can put some forceps through, some long forceps, and do a debridement that way. All right, moving on to the next study from the Dutch pancreatitis group. So now that they had really proven that a minimally invasive approach was better for patients, then the question arose, well, which minimally invasive approach? There's the endoscopic approach and there's the retroperitoneal step-up approach. So once again, the same 19 centers in the Dutch pancreatitis group included individuals with confirmed or suspected infected necrosis, and they randomized them to either an endoscopic transgastric necrosectomy or a surgical step-up procedure, and with the same composite outcome of major complications or death. An endoscopic debridement approach is a transgastric procedure done by an experienced interventional gastroenterologist. In this study, they did this with placing 2 transgastric 7 French double pigtail stents and a nasocystic catheter into the fluid collection, which was irrigated a liter total over 24 hours. If that failed, the tract was balloon dilated, and then a series of instruments were used to, such as baskets, snares, yada, yada, to debride as much as possible. I will say that our interventional gastroenterologists will do a different approach. The first thing that they'll place is an Axio stent, which is a self-expanding metal stent that has these 2 ridges here that'll keep the stent in place. And they'll do an initial debridement through that stent, and that gives them access to go back in for further debridements if needed. And they'll actually leave the double pigtail stents at the very end once the collection has collapsed to a small enough size. And those stents will stay in place for about 6 months until the collection is completely closed on top of those stents. So here are the results of the tension study. And you can see here that there's really no difference in terms of death or major complications between the 2 groups. But when you look at the individual systemic complications, there are fewer cardiovascular complications in the endoscopic versus surgical group, less pancreatic fistula formation, which isn't surprising because with an endoscopic approach, your pancreatic juices are going to drain into your stomach, versus if you place a retroperitoneal drain, you're now creating a fistula out through the retroperitoneum. So this is a much better method to reduce pancreatic fistulas. And the only other thing I want to point out is that on average, there are more necrosectomies required or done for the endoscopic over the surgical group, owing to the fact that an Axio stent is a much smaller window to debride something than a VARD incision. So a VARD is more of like a one and done kind of intervention versus an endoscopic debridement. Usually takes several to get the job done. The last study, which was published in 2021 in the Pointer trial in the New England Journal of Medicine, asked the question of whether delayed approach to a minimally invasive procedure has better outcomes than an immediate approach. So similar study population, these centers were all in the Netherlands from 2015 to 2019, and they included patients who were in the early stage of their disease, so less than 35 days from symptom onset, because they really wanted to capture the acute phase. And they randomized them to immediate drainage, meaning drainage within 24 hours after randomization in the study, versus a postponed drainage group where drainage was postponed until maturity of the fluid collection, so until the formation of walled-off necrosis or clinical deterioration. In this case, they looked at a comprehensive complication index ranging from 0 to 100, with 0 being no complications and 100 being death. And these results were quite fascinating. So I've put asterisks here for the significant results, but you can see here really no difference in death between the 2 groups, no difference in complications, new onset organ failure, or pancreatic fistula development. But if you look at the two groups under catheter drainage, you can see 100% of the immediate group got drained, not surprising. But those who were postponed, 40% left the hospital without any procedure at all. No drainage procedure, no surgeries, nothing. Necrosectomy group, if you look at the rate of necrosectomy, 51% in the immediate group got necrosectomies versus 22% didn't get 22% got necrosectomies in the postponed group. So overall, much lower incidence of procedures and much lower incidence of necrosectomies in the postponed group. So if you recall, taking us back to the 1992 classification, if you remember that quote, which said, while selected patients with documented sterile pancreatic necrosis can be treated without surgical intervention, infected necrosis is fatal without surgical drainage. The investigators of the Pointer study said in their conclusion that these findings suggest that an initial conservative approach with antibiotics alone is justified when infected necrosis is diagnosed. Quite a humongous shift. So, infected neck panc, less is more. That's what all of this evidence is telling us, right? That we should delay our interventions to 4 weeks after onset of disease. Minimally invasive approaches are the way to go. They're better. And that in some cases, we may be able to get our patients through with fewer procedures or no procedures at all with conservative management. But is it really? So we noticed at our center that we were being very aggressive with treatment of these patients. And we asked ourselves, well, how are our outcomes and how does our population compare to these studies? So the first study we did was we looked at patients who had severe acute pancreatitis as a diagnosis who underwent an intervention. And the interventions that we broke them down to was those who underwent a surgery as their first procedure and those who underwent drain placement as their first procedure. So we excluded those who got endoscopic interventions because at our facility, usually our critically ill patients do not undergo endoscopic interventions. So we compared these groups and we found that within the group that had a drain placed, about 57% were successfully managed with a drain, but 43% were not successfully managed with a drain and had to go additional procedures or surgeries. And we wanted to see what were the differences between these three groups. So the first group is the one that was drained successfully. The second group is the one that failed drainage. And the last group is the one that underwent surgery first. And not surprisingly, the last two groups are generally sicker. They have higher Apache 2 scores. So the ones that failed drainage had higher Apache 2s on admission, a higher incidence of a necrotizing subtype of pancreatitis. And if you see, the ones who underwent surgery had a more extensive disease. They had more peripancreatic fluid collections than the other two groups. And if you look at outcomes, you can see that those who failed drainage actually fared the worst, higher length of stay and higher ICU length of stay. And within these three groups, the failed drainage group had the highest discharge to a nursing facility over home. And you can see their death rates were comparable to those who underwent surgery as their first intervention. So this really raised questions in our minds and really asked us whether a blanket conservative or minimally invasive approach is appropriate for all patients with infected necrotizing pancreatitis, as the literature from the Dutch pancreatitis group seems to suggest. But the answer is a little bit more complicated than that. Let's go back to the first case I presented to you, the case of JL. If you remember, this is what her abdomen looked like. So she already had an open abdomen when she arrived to us. This is what her CT scan about 2 weeks after she got to us looked like. Her pancreas was entirely necrotic, so this was consistent with an acute necrotic collection. And she's got extensive fluid collections along her left retroperitoneum to her anterior abdominal wall. And about 2 weeks later, you can see she's developed infected necrotizing pancreatitis. And this was the area that ultimately turned into the coloatmospheric fistula. When she first came to us, the question arises, should we have been more aggressive? Should we have been more aggressive with intervening on her fluid collections using an open approach as would have been done in the 1990s? Or was the minimally invasive approach or more conservative approach better for her? I don't have the answer for that. And really, we have to ask ourselves, has the pendulum swung too far in the direction of non-operative and less invasive management for these patients so that we're applying a one-size-fits-all approach to these patients? If you can take a look at these two CT scans, these patients would be classified. So on paper, these two patients would be classified as having infected neg-panc. They would sound exactly the same. But looking at their CT scans, you can see that they're not. The CT scan on the left has a much greater burden of infected necrosis. So can we really apply the same treatment modalities to both of these patients? And the reality is that open debridement in the modern era has become much safer. These studies were actually done almost a decade, 2 decades ago, so outcomes are probably even better today. But what they looked at was mortality with open debridement. The first is a study out of Boston, where they included patients with infected necrotizing pancreatitis or severe acute pancreatitis, and 22% of that group actually had an early necrosectomy, and mortality was 9%, much lower than the 40% that had been quoted in the 1990s. If you look at this group out of Helsinki, Finland, they have a higher incidence of severe pancreatitis in their study population, similar infected necrosis, a higher rate of early necrosectomy, and their mortality is slightly higher at 22%, still lower than the 40%. And looking only at the ones that got delayed intervention in this study, that mortality was similar to the Boston study at 10%. So the landscape has really changed when it comes to open debridement. So although the Dutch pancreatitis group has made great advancements in our understanding of this disease process, there are several additional questions that we need to ask as to how we're managing these patients. Aside from the radiographic appearance and the extent of the infected necrosis, a key aspect that's lacking in their research is looking at how organ failure dictates management and outcomes, because we know organ failure is associated with greater mortality. So what we wanted to do at our center was see how our patient population compared to the Pointer study. And the first thing that we did was we looked at all our patients with infected collections in acute pancreatitis who had some sort of drainage procedure across a period of around 8 years, so 2016 to 2023. What was our percentage of patients who got drainage? And that was 89%. If you recall, the percentage of patients in the delayed group in the Pointer study who got drainage was 61%. So we asked ourselves, what could be different about our patients compared to the Pointer patients? And really that came down to organ failure. What is the burden of organ failure at our center compared to the Pointer patients? And this study was published by one of our residents, Aisling Zhang, and she looked at all those patients who got drainage procedures or did not in the setting of infected pancreatitis. And you can see here these patients are a lot sicker. So in our study, ICU admission rates are twice as high as the Pointer study, which was the Boxhorn study in 2021. We've got threefold higher rates of organ failure, threefold higher rates of multiple organ failure. And interestingly, our mortality rates are the same as as the pointer study. And the question arises, is delayed drainage appropriate in infected necrotizing patients with organ failure at our center? If a patient comes to us with clinical suspicion for infected neck panc on pressors with a fluid collection on CT, we are not going to delay intervention in that patient. That patient is getting a drain, and they're being followed very closely for further deterioration. So there's a lot that we still need to answer when it comes to these patients. We really need to hone in on who benefits from a delayed approach. I recently did treat a patient who had infected neck panc with antibiotics only, but we really have, and he's currently doing well, but we really have no data on how long these antibiotics should be continued, how much we should be imaging these patients, when do we declare success. And we really need to look at this stratified by organ failure. We also need to think about the subset of patients that should go for open necrosectomies from the beginning and how that relates to volume and location of collections. The answer predominantly is a delayed, minimally invasive approach to most patients with this disease, but there's most certainly a subset, particularly the ones that come to us with open abdomens or end up with open abdomens, that we may want to take a more aggressive approach with. We don't know about their outcomes. And last but not least, how can we prevent progression to infected neck panc? That is really the holy grail here, is how do we prevent it from even forming? The only data we have today that supports the prevention is early enteral nutrition. There's really no other intervention that we know of that prevents progression to infected neck panc. So a lot more research to be done, and it's a very exciting time to be studying this. So thank you very much for this opportunity. This QR code, if you guys scan it, will take you to a folder that has all the PDFs of the studies that I discussed today. And if you have any questions or want to discuss any patients or collaborate on research, please send me an email. This topic I'm very excited about and love to discuss with anyone. Thank you.
Awesome. Thank you so much, Dr. Harfouche. This was a really great summary and overview of a very convoluted topic. So really appreciate you breaking that down for us. If anybody has any questions, if you can put them into the chat and we will communicate those or raise your hand. In the meantime, I'm going to take the privilege of the podium and ask you a couple of questions. So the Axio stents that are being used more commonly now, I've kind of noticed our endoscopists using them in a bunch of different indications, but kind of keeping with the original indication of draining pancreatic pseudocysts. Is there a maximum amount of time that they can be in, or is there another reason that they switch to the double J stents in your institution at the point where more collapse has happened to the cavity?
Yeah, there is a maximum amount of time, and don't quote me on this, I want to say 6 weeks. But yes, there's concern that they'll actually migrate or erode into structures, cause bleeding. So yes, they will remove them as soon as they can. And oftentimes if their endoscopic approach is not working or there's more debridement that needs to be done, you can do a percutaneous approach and upsize to a VARD. Now there's a lot of complications potentially associated with that. You generally want to pick one and stick with it, either a VARD or an endoscopic debridement, but those are possibilities. If you can't complete the debridement endoscopically, you can add another approach.
Thank you. And in terms of the differences between your population and the Dutch population for the pointer study, do you think there are any other kind of differences in your population other than how sick they were in terms of risk factors, or physical or anatomic issues such as differences in BMI between those two populations that may have affected those the rates of organ failure?
Yeah, if I had to take a guess, I'd say our population is very different than the population in the Netherlands. And I don't have that paper in front of me, and I'm not sure they really went into the comorbidities of those patients. But if I had to take a guess, I'd say our patients have more, which is why I think it's so important that we do a multi-center study here in the US that really looks at our tertiary care centers where we're treating the sickest of the sick. So we can find results that are valid to our population.
Absolutely makes sense. All right, we've got a question from Matt Fleming. Once the decision is made for drainage, is there a role for drain irrigation or DPR in open abdomen cases?
I think that's definitely an option. It's not something we do routinely just because our open necrosectomies are so rare. Ideally, if you are doing this, you should be doing it in a very delayed phase where you can easily debride the pancreatic necrosis. If for some reason you're in the abdomen in an open early in the stage of disease, I would say it's still questionable as to whether or not you should be entering the lesser sac and exploring that pancreatic space, depending on why you're entering the abdomen. But if you've entered early and you've made the decision to explore the lesser sac, you're not going to be able to do any debridement. So yes, in that case, I would say put some drains in and try DPR and see if that is successful. But we don't have a clear protocol for that because it's so rare.
Makes sense. A question from Sween Golestani. So our institution uses a lot of ECMO for pancreatitis patients who develop ARDS with mixed results. Do you have any thoughts about the benefits of ECMO, and have you used it often?
Yeah, we also have a lot of our patients going on BV ECMO for respiratory failure, and we've had generally good results anecdotally from what I can recall. So I think it's definitely something you should have in your wheelhouse. A lot of these patients are young, and if you can get them through the early acute inflammatory phase, they will do well. And I think ECMO is a good modality to get them through that early phase.
Thank you. All right, question from Jared Wolgmuth. Great presentation. I couldn't agree more about the need for a multi-center study. Why not expand beyond the USA, especially as you have already found potential differences in patient populations and management approaches and outcomes between the Netherlands and Maryland? Keen to help. I think Jared is in the UK.
I'd love to work with you, Jared. Yeah, more than happy to do an international study, and it'd be very interesting to compare across Europe as well.
Awesome. I'm not seeing any other questions popping up at this point, and it looks like we're pretty close to the end of the hour. I'll throw it back to my other panelists if they have any other additional questions.
That was amazing. Loved your talk. Thank you so much.
Thank you guys for the opportunity.
Thank you so much, and thank you everyone for coming. Just a reminder that if you were inspired by Dr. Harfouche's talk and want to share your own research and insights, remember to submit for the next academic series as well. Thank you everyone for coming. Have a great day.